Professor Mohammed, the floor is yours.
Assalamu alaikum. I hope the voice is okay. الصوت كويس. Is it okay? الصوت كويس?
Yes, it's clear.
Yes, good.
Assalamu alaikum wa rahmatullahi wa barakatuh. It's really a pleasure to be with you. Thanks, Faisal, for the nice introduction. And particularly, I thank Ashwaq for her enormous effort in keeping this frequent meetings going. And Dr. Khalid Kaplan for sure his effort in driving this to be done on a regular basis. Actually, I'm talking. I wish I'm with you. I'm talking to you from Al Qasim, and we're attending some activities for the Saudi charity, the Liver Saudi, or the Saudi Liver Charity Organization, which is really has expanded its services and has progressed very well in the last few years, trying to reach patients, liver patients who need treatment. And I'm sure you'll hear about already some people are involved in it from this gathering, and I'm sure others will be involved in it. That its main aim is to try to bring patients who need treatment or transplant to proper places and be able to help these patients. So this is the agenda of my talk, and basically I will, as you can see, several issues, but I will try to concentrate on the eligibility criteria and where transplant and or surgical management in general sits in between many available ways of treating hepatocellular carcinoma. This is the first patient we did. I don't know.
Would
do you have the picture? Or
would you please share your PowerPoint presentation?
Hello?
Doctor?
You hear me all right?
Yes.
Can we have the slides of Professor Alsebayel, please? Can we have the slides projected, please?
Are we okay, Faisal?
We're waiting, for the, yes, now the slides are there. تفضل.
Okay, so this is the first patient we did back in 2001 at King Faisal Hospital. This is a patient, as you could see, who has hepatitis C and hepatitis B and hepatocellular carcinoma within the criteria. And actually, he was the first living donor transplant done at King Faisal back in 2001. He is still alive and well. We did him in his late 50s. Apparently, also Thomas Tarzan, when he did his first transplant, successful transplant, was for a patient with hepatocellular carcinoma who survived, I think, more than a year. So this is a bit of epidemiology you heard in the first lecture. Basically, it is a killer. And it is not that uncommon. And basically, the incidence is similar to the prevalence, since most of the patients they die in the first year. This is something we developed. I developed with Dr. Ayman Abdu when he was working with us, trying to figure out what will be the expected number of patients who basically who's in the domain of liver disease. And we put this theoretical model a few years ago, and basically we thought that the annual incidence of cancer would be something like 3,000 to 5,000. Probably these figures are not far from the truth. And the diagnosis, as we know, doesn't need biopsy. Everybody goes with CT and or MRI. In the presence of liver disease, and when you see the washout, washing, this is the diagnosis. And as you know, the prognostic staging system for HCC, there are many staging systems. Probably the most, all of them are, or most of them, the core is the child scoring system, and the most common, as you know, is the Barcelona scoring system. And in this area, early on in early stage A, this is where transplant comes. However, Some of the intermediate stage, as you know, could be downstage, and we'll be able to offer them transplant. Of course, when we look at options for the patient, we look at the patient, and we look at the tumor, and we look at the liver, and this is the strength of BCLC. And of course, this could be achieved only by a multidisciplinary team where surgeons, radiologists, oncologists, and hepatologists sit together and figure out what is the best for these patients. The next thing is the place of surgery and the management of hepatic cell carcinoma. Talk about the eligibility criteria and the expected outcome and the limitations. Surgery remains the gold standard for curative strategy for hepatic cell carcinoma. Very quickly, we'll go over what type of surgery we do or what type of resection we do. You can do a left lateral segment, left lobe. You can do a full left lobe, as you can see here, or you can do a right lobe, or you can extend the resection to extended left lobe or extended right lobe. This, of course, will depend on anatomical reasons as well as the function of the liver. And the incision we use is this type of incision now. Minimal invasive surgery is taking a place in
Dr. Mohammed, we are showing your slides here centrally. Please let us know when to move the slide forward.
Okay, I cannot control it. I can't control the slide from my side.
If you have the PowerPoint, please show it from your side, if you'd like to do that. Share it.
Yeah, I'm sure. Just let me just give me a second. I will try to figure it out. Sorry. Is it coming now? Hello?
Not yet. We don't see your
Okay,
presentation.
Professor Mohammed, you can say next, and they can move your slide if you would like, and just let the technical support control the slides.
Okay.
Dr. Mohammed, currently we are showing your slide.
Yeah, okay. I just moved this slide. Tell me if it is moving. I'm moving this slide. Is it moving?
No. You are not sharing your screen. If you can have a look at the screen, the Zoom screen, we are showing your slides already. Please confirm if this is the correct one, and you can say next when you are done.
Okay, share screen. How is it now? I'll just move it.
Yes, we can see it, and it's moving.
Okay,
you can continue.
Okay, sorry for this. So I'll just go back to very quickly over the slides. It's moving now, right?
Yes,
it's moving now.
Yes, it is.
Okay,
yes,
very good. So this is the incision. I was talking about the incision. These are the incision. Nowadays, we can do laparoscopic surgery in some selected patient, and the recovery of the patient is quicker, and we can obtain the same results. And this is just some slides showing you the stages of the surgery. This is hilar dissection, where we dissect the structures in the hilum, the portal, the hepatic artery, and the duct. And then this is continuation of hilar dissection. This is a hilum. You can see the portal vein here, the artery, and the duct. And this is the right portal vein being circled. And this is showing you the right hepatic vein being dissected. And this is mobilization of the liver, where we mobilize the liver from the cava, and this is clamping of the right hepatic vein. And then we go for parenchymal transection, which can be done through several techniques. These are some finger fracture, ultrasonic dissection, water jet, and the most important, of course, is controlling of the bleeding with diathermy, suture ligature, RFA, and so on. And this is an example of transection of the liver. As you can see, the left lobe is separated from the right here. And here you can see the left portal vein being separated. And this is an interesting slide where you can see the middle hepatic vein where we separate the right lobe from the left lobe. So doing a resection, we should be safe, and we benchmark resection to the benign regions where the mortality is supposed to be 0, morbidity of 31%, and we try to achieve these kind of figures, which are applicable to the benign lesions. And of course, this will depend on other factors other than the liver, the condition of the morbidity, of the comorbidity in the patient, and so on. And these are historical studies showing you excellent outcome with resection, and this is which is comparable to transplant. And of course, there are certain selection criteria for this. So the resection in cirrhotic is best for a single lesion for an asymptomatic patient with preserved liver function test. And Lovett back in 1999 defined the criteria for good survival after resection, including preserved liver function test with these parameters: platelets more than 100. And the hepatic venous gradient of 10 and normal bilirubin. In this situation, survival of 70% could be achieved in 5 years. However, a small percentage of these patients will meet these criteria. So curative strategies could be attempted in 1/3 of all patients. Resection, ablation, we heard about ablation a while ago, and liver transplantation. And there is no comparative studies looking at comparing these strategies to transplant in compensated patients. So the resection for hepatocellular carcinoma, the limitation is anatomy and the presence of cirrhosis. Whether resection or transplantation will depend on many factors, including, of course, as we know, the donor issues. In general, child classification, again, is a good way of trying to assess the amount of resection you could do in a patient. Child A, you can do a formal resection right or left lobe. Child B, you can do 25. Child C, never beyond 15, or maybe you shouldn't do it at all. The resection in non-cirrhotic is rare, supplied in only 5% of the patient, and in these patients you can actually leave only 15 or 20% of the parenchyma. Result of resection with bad prognostic factor are bad, although there are some reports from Eastern Asia, Japan, and so on, indicating some reasonable result. But with the clinically relevant portal hypertension and jaundice, the survival can be as low as 25%. The recurrence after resection is related to microvascular invasion, differentiation, and satellite induced. These are bad prognostic factor in the resection specimen, which tells you that the patient is most likely will have a recurrence. Of course, the safety and accuracy is very important in getting an outcome, depending on the surgical technique, perioperative care, and patient selection. So with this, we have the best candidate and the second to best candidate, those with portal hypertension, with those with limited functional capacity, those with multiple tumor, vascular invasion, and combined condition. These are the patients where you know their resection will be done on exceptional basis based on many other factors. As we saw, these are the criteria for selection. Now, as MED score has been introduced as another way of looking at the functional capacity of the patient or the remaining part of the liver to decide how much you resect. And basically, the optimal surgical candidacy is based on a multi. This is actually this is from EASL guideline regarding resection, based on multi-parametric evaluation to include compensated liver function, meaning child A, MELD score below 10, acceptable amount of remaining parenchyma, and possibility to adopt laparoscopic and minimal invasive approach, which has got an advantage over the open technique in some condition. The combination of the previous factor should lead to expected perioperative mortality of less than 3% and morbidity of less than 20% and a post-surgical liver failure incidence of less than 5%. And this is a drawing a recent, not very recent, it's 2016 actually, in JAMA, showing you the combination of MELD score as well as portal hypertension parameters in order to decide which one is low risk, which one is intermediate, and which one is high risk. So surgical resection is recommended as treatment of choice in patients with HCC or non-cirrhotic patient. Indication for resection in HCC and cirrhotic should be based on assessment of liver function, portal hypertension, extent of hepatectomy, and expected volume of future liver remnant and performance status of patient. Perioperative mortality of liver resection in cirrhotic patients should be, as we said, less than 3%. Liver resection is recommended for single HCC of any size, although now we extend it to even more than one lesion and up to 3 lesions. Liver resection should be considered via laparoscopic or minimal invasive. Now, why not to do transplant rather than resection on everybody? The answer is obvious. There's a price you pay if you do transplant, immunosuppression, as well as you can have organ, as well as you can have side effects of the immunosuppressive drugs, and of course the availability of organs, organ shortage, which is experienced everywhere in the world. Now we'll go for the eligibility of transplant as it relates to other management modalities. And there are questions about bridging and downstaging, which we use in the future transplant candidate. And there are several questions which really not answered, although we're gradually seeing answers to these questions. Is the patient within transplant criteria? Which means does he need a new adjuvant or downstaging? Come to waiting list priority, especially that the patient is competing with living and cadaveric. Are they different? And then we have to look at the advantage of the community versus the individual when making the decision about priority in the waiting list for transplant. Currently, 1/3 of half or to half receive a new adjuvant while on the waiting list, especially if you're talking in a program where they do cadaveric transplant mainly, and certainly decreased dropout from the waiting list, and according to UNICEF data, better post-transplant survival in patients who undergo bridging with either TACE or RFA. It's been found that full response to TACE will have a better survival than partial best evaluation for a patient who eventually will drop out from the transplant list. And therefore, the recommendation new adjuvant should be offered if it doesn't delay the transplant. And of course, the big question is the criteria for transplant in living donor-based program versus cadaveric-based programs. And the downstaging, also there's these questions which need to be addressed: which tumor to be downstage, meaning the inclusion criteria, and what to use, what are the criteria for success, when to do the transplant, and what kind of survival outcomes accepted, and what is the price we pay for all of this. So the entry criteria for the downstaging or bridging depending on the size and number of total volume, biological, molecular, or pathological characteristics, and definition of success of that downstaging will be depending on radiological, be it size or process, and biological, meaning the level of alpha fetoprotein. These are some of the publication we did in HCC based on our experience with liver transplantation. And we've been in our downstaging, bridging, we've been using basically RFA and radioembolization. Extensive experience now at King Faisal with radioembolization over the past, I think, 12 years or so. And this is an example of tumor necrosis. This is an explant. A patient was transplanted. This is explant. You can see the effect of radioembolization, complete necrosis of the tumor. And this is normal. The one I showed was normal liver. This is the necrosis. As you can see, these are the beads of radioembolization, and you can see complete coagulatory necrosis in the specimen. This is a small study we did, and actually this study is more of looking at our quality control of the program. Are we selecting the appropriate patients for transplant, and what is the outcome? And basically, and this is a very inhomogeneous group of patients. Some of them receive living donor, some of them receive disease donor. This is when the program was up to 600 transplant, and 25% of the patient transplanted were hepatocellular carcinoma. And basically what we did, we put them in categories: those with Milan, with bridging or downstaging.
Dr. Mohammed, we would appreciate if you can finish in 2 minutes, because
okay.
Thank you. Right. We're running late. Thank you.
Okay. And so the different stages with new adjuvant therapy. And basically, we found an overall survival, which is similar to the survival of patients without HCC. And then when we put the categories of patients, also there wasn't a difference in terms of significant difference in terms of survival, except for patients who were in the waiting list, and we do bridging. There was tendency towards the better survival, which goes with other stuff. These are EASL guidelines. Probably I don't need to go into them for the sake of time, but basically summarize the EASL guideline, and the EASL guidelines of 2018 are based on level of evidence and the recommendation. And you can see these are the ones which in the right-hand side, which prove to be highly recommended and with strong evidence: resection and living donor liver transplant within Milan, resection and ablation, as well as RAFNIP has been recommended with good level of evidence. Very quickly, so this is Milan. The problem with the patients who were put in the cadaveric list is doubling time of HCC is quick, so you can lose them while in the waiting list. Therefore, that's the reason why we bridge them. Several system for selection. One of the famous now is the metro ticket. These systems are depends on basically on the morphological size of the tumor, and the more the number and the more the size, the worse will be the prognosis. And this put in what you call the metro ticket. The longer the trip, the higher the price you pay. Then more than morphology, Kyoto Group in 2007 included PIPCA as a factor for selection, and then other Asian group included alpha-fetoprotein, and then Western countries also follow the trend of using biological factors, and then the metro ticket included also alpha-fetoprotein in the selection, and then the radiological response, which I think is making a big difference in terms of selection of patients for transplant. And basically, this is a study which is done published recently, looking at using metro ticket 2 plus MRISIT for response of treatment in patients who are not candidate by morphology for transplant. And this can refine the selection for patients for selection. This is just an example to show you how can RISIT staging can help us in deciding which patient to transplant. So this is a patient you can see from morphology selection criteria. Most of the system for selection criteria, the patient is out, but when you downstage and look at the functional part of the tumor, then they could be transplanted with a good 5-year survival. So very quickly, either selection system for transplant should have 5 years disease-free survival of 50%. If the transplant is too early, then it's to be futile because of the rate of complication as well as mortality. It should be easy use. It should be dynamic rather than with all morphological way of assessing patient. And morphological plus biological tumor marker characteristics should be used. Pre-transplant diagnosis of microvascular tumor may be of value. PIVKA2 and alpha-fetoprotein should be used. Living donor liver transplant has changed now from high risk, high return to a low risk, high return. So it should be probably included more in the selection criteria. So I will not go. This is systemic review, actually, a recent one looking at what is done now. There is 59 different inclusion criteria of HCC for liver transplant. So still we are in a situation where there is a lot of debate of whom to take for transplant and whom to exclude. Very quickly, I'll just show you the number of transplant in the kingdom has been increasing. And nowadays, from 1990 until now, there is more than 3,000 transplant, and currently almost every year a total of 200 transplants are being done. And therefore, this is an opportunity to be able to help to transplant patients with HCC, and also a way to explore the different possibilities of approaching HCC in a multidisciplinary fashion. Just concluded this slide. Changing the management of HCC is dynamic, especially those related to selection criteria. The role of downstaging to include more HCC patient is expanding. The old criteria are too restrictive. Criteria for selection is being refined to include biological and dynamic, and I stress the dynamic factor, as well as maybe the future, the histology as well. Living donor liver transplant will present a unique opportunity to explore expansion of selection criteria. Tools for advancement in the management of HCC are uniquely available in Saudi Arabia. Why? Because we have an excellent hospital facility where multidisciplinary team are available to handle these cases. And nowadays, 75% of the transplant in the kingdom is living donor, so we have more opportunity of offering transplant for patients with HCC. And also we have a big potential for cadaveric expansion. So really we have a unique opportunity where we will be able to explore the opportunity in dealing with patients with the hepatocellular carcinoma from the perspective of not only for transplant, but as well as other multidisciplinary areas. Thank you very much, and I'm sorry if I took time more than what I should.
Thank you very much
for this very informative lecture. Thank you so much. And we're running late, but we have some time for a couple of questions. There is a question to Dr. Arabi. One of the attendees asked if there is any difference between different chemotherapeutic agents used in embolization, or you think it's an embolization effect and if there is any difference, which we think is better. Dr. Arabi, are you with us?
So as I understand, the question is any difference between chemoembolization and embolization alone? That's the question?
The difference between the outcome between tear and TACE. Is there
okay,
any
yes,
difference?
okay,
Or is it the embolization effect, or is it also the modality?
No, actually, with the radioembolization, the embolic effect is quite limited because the number of embolics is quite small compared to what we use in chemoembolization. So it's not the embolic effect when we compare TACE to TARE, it's actually the radioactivity versus the chemoembolization. So it is the radioactivity itself with beta emission that induces the tumor necrosis. While in chemoembolization, we have both the embolic itself as well as the chemotherapy that's injected, whether it's conventional TACE or the DEP TACE. So the comparison is it's not the embolic effect, it's actually the radioactivity versus the chemoembolization effect.
And Dr. Arabi, do you think that TARE is more effective than chemoembolization?
Well, I think in select patients, yes, it might be better, but we have to be extremely selective in choosing the patients. As the studies showed, smaller, like solitary HCC lesions smaller than 8 centimeter, it might be more effective than TACE. Nonetheless, TACE is the standard of care as per all the guidelines for intermediate stage when we have multinodular lesions with lobar versus like non-lobar treatments. But I think in select patients, yes, it is radioembolization seems to be more effective than TACE. And probably the durability of treatment is better.
Also, Dr. Arab asked if there is a difference between like doxorubicin and irinotecan. You think there is a difference between the chemotherapeutic agent used?
Most of the studies on DEP TACE are done with doxorubicin. Irinotecan is being used and offered for metastatic colorectal cancer, not for HCC. If you look at the conventional TACE, we have several protocols, including cisplatin, mitomycin, adriamycin. So it's not as standardized as the DEP TACE. DEP TACE, most of the time we use doxorubicin. In some publications, they use epirubicin, not irinotecan. Irinotecan is not being used for HCC.
I have a burning question regarding immunotherapy in liver transplant patients. And one of the attendees also asked a similar question. My question, if a patient has cancer either in the liver or outside the liver and they are liver transplant recipients, Dr. Ali and Dr. Alsebayel, do you have any experience of the use of immunotherapy in liver transplant recipients? We know that in the literature it's written as contraindicated, but I would like to know if you have any experience.
No, not immunotherapy. But in general, the immunosuppression to start with for patients with HCC is similar to any other patient, and then gradually you try to taper it down. The patient I showed you before, the first page, and it is sometimes dangerous to stop or try to produce the immunosuppression very quickly. The patient I showed you in the first slide, actually he was on 0.5 after about 15 years of his transplant. He was on 0.5 milligram of tacrolimus every other day. And so we thought that we will stop it, since it's very little immunosuppression. And when we stopped it, his enzyme jumped to high levels actually a few days after we stopped it. You try to minimize immunosuppression, but at the same time, don't overdo it. Otherwise, you'll end up by recycling the patient with steroid and so on, and making the situation even worse.
Ali?
Yeah, fortunately, the recurrence rate also in our center has been quite low. I mean, in a recent review we did, even those who are outside Milan, meeting San Francisco criteria were actually up to 6%. But we don't refer them for, immunotherapy, basically because we are afraid of bad rejection.
What about pre-treatment with immunotherapy? Would you consider transplant?
If the patient was treated with immunotherapy and achieved an excellent response, I have to say that we haven't encountered any patient like this. We had one patient who responded to TKI and with alpha-fetoprotein of more than 50,000, and then normalized only with sorafenib, and the lymph node disappeared. I mean, the uptake, and then he was successfully transplanted. That was only one patient that I know of, but not a patient with immunotherapy.
Faisal, I have a question for Ali. Do you think now at HCC we can customize therapy, whether immunotherapy or TKI, based on the etiology, like hepatitis B, hepatitis C, or NASH?
I think, yeah, there are some studies which are saying that, okay, the outcome is better in certain group patients, especially with patients with viral hepatitis. But honestly, I think it's still too early to say that. Maybe still we need a more solid evidence to start, selecting patients based on the etiology. And for now, we do treat them with their HCC based on this stage rather than their etiology.
Great. Thank you very much. Unfortunately, because we run out of time, we have to conclude, although we have a few questions, but we run out of time. I would like to thank all our speakers. Excellent first session to get the basis ready for more talks on actual chemotherapy and advances in the chemotherapy, as Dr. Ashwaq will lead our second session. Thank you very much, everybody. And we will have a break now. And Dr. Ashwaq, the floor is yours.
Thank you, Faisal and Fuad. Professor Bayel, thank you very much, Mohammed and Ali, for excellent session. So now we go for 10 minutes break, then we'll go back for the Satellite Symposium sponsored by Lilly. So break for 10 minutes.